Good afternoon to everyone. A very good afternoon to all. So we are going to start a new page in fetal medicine in SFM Mumbai chapter, and this is called the Young Guns. So this is the brainchild of Alok Vashne, who thought that all the young students should also present cases and not always have the leaders only presenting cases. So this is a very good initiative by Alok Vashne under Dr. Ashok Khurana, our greatest mentor, and we also have Dr. Mohit Shah, who is the president of SFM, and myself from SFM Mumbai chapter. So today we have a very beautiful list of cases, and all of them are actually very rare, and the presentations have been very well taken through. So we will go through all of them, and we all will learn from whatever we see today. And they are beautiful cases, and we'll have discussion in the end of the cases that we have. So I think we will start. And for this, Shlok Lodge is my secretary from Mumbai chapter, who's going to take us through all these cases. And Shlok, you can take over and introduce the first speaker.
Surely, madam. Thank you
Yeah.
so much. And at the outset, again, I would thank Dr. Khurana sir, Dr. Mohit Shah, and Dr. Alok Vashni for this great event. So our first speaker for tonight would be Dr. Lakshmi Vishnu Bangar. She is a working consultant at Arc Diagnostic Mumbai, and she has done a fellowship in fetal medicine. So I would invite Dr. Lakshmi to share her slides. Dr. Lakshmi.
Yes, sir. Am I audible?
Yes.
Okay.
Yeah.
So, good evening, everyone. First of all, I would like to thank Dr. Khurana sir, Dr. Mohit sir, Dr. Vandana madam, Dr. Alok sir, Dr. Shlok sir for giving me this opportunity. Let's go to the case. We had this case when I was working with Dr. Varun Thakur in Pune. There was this 29-year-old mother who was referred to our clinic for the second opinion in view of bilateral club fit at 24 weeks of gestation. She was primary gravida. This was her spontaneous conception. There was no history of consanguinity, and first trimester screening was not done. So these were our ultrasound findings. There was polyhydramnios. Here you can see bilateral club feet. There was genu recurvatum. Also, you can appreciate here there is a paucity of soft tissue over the legs. 3D images showing the same thing. Also, there was fixed flexion deformity of both the elbows, wrist, with clubbing of hands and persistently clenched fists. There was skin edema over the trunk, also on the scalp. Thorax was narrow with bilateral mild pleural effusion, as we can see here. So, in summary, these were the findings. All these findings were suggestive of arthrogryposis, which could be due to syndromic or genetic etiology. For the same reason, parents were offered amniocentesis and genetic testing. They opted for termination of pregnancy. These are a few picture of abortus. Here we can see clubbing of feet, flexion deformities of elbow, wrist with persistently clenched fist. Here we can appreciate the paucity over the soft tissue of the legs. Testing of the abortus was done, which showed the fetus being heterogeneous for likely pathogenic variant in the gene associated with congenital myopathy 2A and 2C. Both these conditions were autosomal, were showing autosomal dominant inheritance pattern. So what is arthrogryposis? First of all, it is not a diagnosis, it is a descriptive term. It is defined as more than 2 joint contractures in more than one body area. Importantly, it is marker of abnormal neurological development or primary muscular disorder. So what are the findings which would prompt us to look for arthrogryposis? Polyhydramnios is usually seen beyond 25 weeks of gestation due to lack of swallowing. Polyhydramnios, when usually seen with persistently small stomach, first thing that comes in our mind is tracheoesophageal fistula. However, if we assess the fetal movement and if there are decreased movement, polyhydramnios with this persistently small stomach can be a feature of evolving arthrogryposis. In first trimester, we can see increased nuchal translucency. There could be club feet, persistently clenched hands, brain anomalies, spine anomalies, micrognathia, and pulmonary hypoplasia. In presence of polyhydramnios, brain anomalies, pulmonary hypoplasia, and hydrops, these are the indicators of guided prognosis. When in doubt, we can ask the patient to come after the interval of 2 weeks to confirm the findings. So what are the causes? Extrinsic causes and intrinsic causes could be there. So we need to ask for the history of any maternal viral infection, as viral infections of Zika, rubella, or Coxsackie can be associated with arthrogryposis. Whether there is any history of exposure of teratogens to the mother, like phenytoin or ethanol, whether the mother is having a history of myasthenia gravis. It could be due to reduction in the intrauterine space, which could be because of large uterine fibroids, congenital uterine malformations, severe oligohydramnios. When we see intrinsic causes, there could be chromosomal abnormalities like trisomy 18, trisomy 8. There could be microdeletion, duplication, single gene disorders. So we need to ask for the history of consanguinity. We need to ask whether there is any positive history in the family, any family member having contractures, or their previous baby with similar picture. As more than 350 gene variants are associated with arthrogryposis, here we will discuss few lethal neuroarthrogryposis, which all of which show autosomal recessive inheritance pattern. We'll see them one by one. In a severely growth restricted child, if we see polyhydroxyneos and arthrogryposis with severe pulmonary hypoplasia and hydrops, along with shortening of long bones, micrognathia, or clefting, we should think of fetal akinesia deformation sequence. It is called a sequence because it is a common pathway to various pathogenic mechanisms. It is not a single disease, single neuromuscular disease giving rise to this picture. When we see arthrogryposis with distinctive facial features like low set ears, microphthalmia, micrognathia, with severe hypotonia and these features, we should think of cerebro-oculofacial-skeletal syndrome. In arthrogryposis, usually the upper limbs are in persistently flexed position and lower limbs are in persistently extended position. However, in multiple pterygium syndrome, there would be flexion of all the four limbs with webbing seen around the joints. There would be facial clefting, micrognathia, and growth restriction. New Luxovu syndrome is characterized by severe microcephaly in growth restricted child, which shows sloping of forehead. There is a proptosis of eyes, hypertelorism, external ear abnormalities. Lymphedema can also be seen over the limbs. And specific CNS findings like agenesis of corpus callosum, severe cerebellar hypoplasia can also be seen. In later gestation, lesioncephaly can be detected. So what is next after doing this thorough ultrasound examination? So these cases of arthrogryposis should be investigated with whole exome sequencing along with FISH and chromosomal microarray, as multiple genes can be involved. When we know the causative variant, which is found in the affected family member previously, we can directly go for targeted molecular testing. In untoward events like termination of pregnancy or stillbirth, we can do autopsy of the abortus. Evaluation of the parents is also important because it let us know whether the parents are having carrier state, and in turn it helps to know the risk of recurrence in future pregnancy. According to the history, we can do a test for maternal viral infections and autoimmune disorders like myasthenia gravis. Most of these conditions are lethal antenatally. High mortality is noted in first few months of life. In some instances, the babies may survive beyond neonatal period. often requiring orthopedic and extensive physiotherapy, but the quality of life is poor. Recurrence, as we discussed earlier, it depends upon underlying condition. It can have causative agent from abnormal chromosome to multiple single gene disorders. We can have autosomal dominant, autosomal recessive, or like X-linked pattern of inheritance. So depending upon those conditions, recurrence can be there in future pregnancy. So my take-home message is arthrogryposis is a descriptive term and not a diagnosis. Detailed ultrasound examination is necessary. Genetic testing should be offered to know the etiology and to calculate the risk of recurrence in subsequent pregnancy. Multidisciplinary approach with pediatric orthopedic surgeon, pediatric neurologist, physiotherapist, and geneticist is required. We need to counsel the parents that none of this musculoskeletal tissue around the joint is normal. Most of these conditions are lethal. And even if the baby survives beyond neonatal period, our aim would be to rehabilitate the child. Thank you everyone for the patient listening, and special thanks to Dr. Varun Thakur for being incredible mentor. Thank you.
Great. Thank you very much, Dr. Lakshmi, for a crisp talk on arthrogryposis. I would invite Dr. Archana Thakur as our next speaker till the time she shares her slides. I would describe about Archana. Dr. Archana Thakur has been a fellow with Dr. Vandana Bansal, and she is now a fetal medicine consultant at Surya Hospital. So, Dr. Archana, please start with your talk.
Yes, sir. Sir, am I audible?
Yes.
Good evening, respected seniors and dear colleagues. I am Dr. Archana Thakur. I did my fetal medicine fellowship under Dr. Vandana Bansal madam, and I am thankful to the madam for all the opportunities. And I would also like to thank Shlok sir, Alok sir, and Ashok Khurana sir. Today I am presenting the case of Prader-Willi syndrome. Antenatal diagnosis of the case is rare. My patient is 35-year-old primary gravida. She is 31 weeks gestation with IUI conception with decreased fetal movement since 1.5 months. She is married since 3 years and no history of consanguineous marriage. And there was no history of smoking or any drug intake like sedatives or opioids. In her anti and anomaly scan, there was no sonographically detected anomaly noted. Her double marker test was low risk and uterine artery Doppler was normal. She was having persistent decreased fetal movement since 26 weeks of the gestation. And for that, she had multiple ANC visits and multiple ultrasounds. And these are the various ultrasound reports that was showing decreased biophysical profile, persistent breech presentation, and normal Doppler studies. But no conclusive diagnosis was made, and patient was referred to our center for second opinion. These are the images from our institute. And there was polyhydramnios, and baby was not showing any movement at all. And it was polyhydramnios, and there was passive floating of the fetus in the pool of liquor. And there was normal Doppler study. MCA and umbilical artery Doppler was normal. Uterine artery Doppler study was normal. Brain anatomy was also normal. There was no ventriculomegaly, no callosum anomaly noted. But the growth was along the 5th centile, and SE was along the 4th centile. So what could be the differential diagnosis? It can be fetal growth restriction, arthrogryposis multiplex congenita, or more severe form of skeletal dysplasia like fetal echinacea deformation sequence, multiple pterygium syndrome, or it could be the chromosomal anomalies like Prader-Willi syndrome and Angelman syndrome. So the couple was informed about the ultrasound finding and the need of amniocentesis to rule out musculoskeletal abnormality and genetic abnormality has been explained. And the procedure-related risk was also explained. Amniocentesis was done, and the sample was sent for FISH chromosomal microarray and whole exome sequencing. And in the whole exome sequencing and the chromosomal microarray report, there was pathogenic copy number variant detected that was on chromosome 15. 15q11.2q13.1 was the critical region, and there was SNRPN and UBE3AG. And this critical region is responsible for both the syndromes, Prader-Willi syndrome and Angelman syndrome. And other aneuploidies were reported negative. FISH was also reported normal. This heterozygous deletion In this critical region, 15q11.2, q13.1 region, that is pathogenic for Prader-Willi and Angelman syndrome, may increase the susceptibility to neuropsychiatric and neurodevelopmental disorders. And to differentiate between two, the test is MS-MLPA, methylation sensitive multiplex ligation probe amplification test, but it could not be done because of its unavailability. However, there was no microcephaly, no ventriculomegaly in the ultrasound. So diagnosis goes more in favor of Prader-Willi syndrome. So couple was provided with the detailed counseling on possible neonatal course and lifelong multidisciplinary care by fetomaternal specialist, geneticist, and pediatrician. Due to potential challenges, the couple decided to discontinue the pregnancy. And the fetal reduction and termination of pregnancy was done with the permission of medical board. Patient was induced and patient delivered with the breech. It was phenotypically normal dead male fetus with a 1.85 kg. This slide is showing the difference between Prader-Willi and Angelman syndrome. So the critical region is the same for both 15q11.2, q13.1. Whenever there is a loss of paternally active genes, that is Prader-Willi syndrome. And whenever there is loss of maternally active genes on the same region, it causes Angelman syndrome. Angelman syndrome babies are having severe mental retardation, and these are the happy demeanor babies. And the characteristic facies will be microcephaly. In an ultrasound, there will be ventriculomegaly. So according to the geneticist opinion, the chromosomal microarray of the parents was also done, and there was no copy number variant detected on the same critical region. That confirms the de novo status in the fetus. The couple was counseled for the low risk of recurrence in subsequent pregnancy. And whenever there is the deletion defect, so there will be the low risk for recurrence in future pregnancies. This one study I would like to quote that is conducted in Israel National Institute. This is retrograde study. The 99 babies of Prader-Willi syndrome are compared with their closest siblings and general population, and the history given by the mother and with their mothers of antenatal records when they were pregnant with these babies. Because the antenatal diagnosis is rare, that's why it is retrograde study. So the common findings that are comparable with this case are the polyhydramnios, decreased fetal movement, cryptorchidism in male fetus, breech presentation, small for gestational age, and fetal growth restriction. So now the overview of Prader-Willi syndrome. It is a rare disorder and antenatal diagnosis is also rare. And the key features are hypotonia, feeding difficulty in infancy, and hyperphagia in adults. And the genetic basis is loss of function of paternally active gene on chromosome 15 and on the critical region 15q11.2, q13 region. And the genotypes are paternal deletion means the loss of paternally active gene, maternal uniparental disomy means both the copies of chromosome are coming from the mother, no copy from the father. And imprinting center deletion defect means the alteration in DNA methylation that causes loss of function of imprinted gene. And the last one is a rearrangement defect, that is like Robertsonian translocation 15/50. And whenever there is imprinting center deletion defect or rearrangement defect, there is sibling recurrence risk is more than 50%. And chromosomal microarray is the test of choice, can detect this deletion in this critical region. But to differentiate between the two, the test is MSMLPA. And the potential complications are endocrine complications, neurological complications, and musculoskeletal complications. Lifelong management and treatment is required. Growth hormone therapy, dietary therapy, behavioral therapy, and physiotherapy to support the motor skills. And the average lifespan of these babies without obesity is 30 to 40. With obesity is 30 to 40, and without complications, it is 60 to 70. So the one living example is American actor and singer Chris Burke was born with Prader-Willi syndrome. And with the early intervention, obesity prevention, and lifelong care, he's living a good life. He's 60 years old now. So the conclusion and key takeaways are: decreased fetal movements may not always be due to hypoxia. It may have complex causes, and genetic factors may play a significant role. Investigating genetic conditions and microdeletion syndromes can provide accurate diagnosis that will help in genetic counseling and will explain the poor perinatal outcome. And the accurate diagnosis reduces the unnecessary blame on gynecologists in cases of poor perinatal outcome. Thank you. Thank you so much for patient listening.
Brilliant talk.
Mm.
Dr. Archana, it was a brilliant talk on Prader-Willi, and you have completely covered all the genetic background and all the aspects. Now, I would invite Dr. Revati.
Shlok, let me just discuss these two cases that have been
Yeah, sure,
presented.
sure.
both of them have been decreased fetal movements and a diagnosis was different. So in the first one, it was arthrogryposis. So you have to keep your mind open. The presentation was so beautiful that she has differentiated different types of arthrogryposis with multiple pterygium syndrome with other disorders. And what Archana has presented is something different, which is an imprinting disorder, so Prader-Willi. So decreased fetal movements for obstetricians, you need to understand it is not always IUGR, oligo, Doppler's abnormality. It could be a lot of more things. So these two we put together is because they are different presentations of decreased fetal movement. One was contractures and one was just no movements and floating in the liker. So you need to think out of the box when you see something different. So I think these two, and the genetic disorder was also different. First one was an autosomal dominant disorder where the recurrence is again not there, and Dr. Lakshmi presented. She also got a pathogenic variant which was autosomal dominant. So the parents would not have
Myopathy.
this, and so recurrence would be less in your case. And so it was tested, and that is why you were able to reach a diagnosis. And same way for Archana also, your case was picked up and you got the diagnosis and you looked at the parents and the parents did not have it. So you could at least tell her for the next pregnancy the recurrence is less. So the test done in the first and the test done in Archana's case were completely different. And so what test to send is to be decided. And I think we should always involve a geneticist whenever we have such rare cases. So beautiful presentation by both of you. So Shlok, you can take over.
Yeah, excellent points, ma'am. What you have covered, and that is what experience tells. So decreased fetal movements. Watch out for all these factors. I would now invite Dr. Revati Tekwani. Uh, Dr. Revati, please share your slides. Dr. Revati is assistant professor in the Department of Radiology, KEM Hospital, and she would be talking about unilateral echogenic fetal lung lesion. And again, think beyond CPAM, like think out of the box. The concept is. So, Dr. Revati, please start your talk.
Yes. Hello all. So I am here to talk about a case of unilateral echogenic fetal lung lesion under the guidance of Dr. Hemangini Thakkar, Professor and Head, Department of Radiology, KM Hospital. So basically a 27-year-old woman, primi gravida, came to us in her late second trimester for a scan at 27 weeks of gestation. No first trimester combined screening was done. No malformation scan was done before. The woman was healthy with no comorbidities. So we did the fetal ultrasound for the patient, and what we found was a large.
Your slides are not moving. Yes.
Okay, ma'am.
Yes. Yes. They are okay
Ma'am,
now. Yes.
is it okay now? Okay, thank you, ma'am. So we did the fetal ultrasound where we found a large echogenic lung mass in the left side of the chest, which was shifted the heart towards the right side with compressed right lung. Also on color Doppler, there was hardly any vascularity and there was no discontinuity of the diaphragm. So based on these findings, my differentials were congenital pulmonary adenomatoid malformation, most likely, congenital lobar overinflation, less likely as there was no hypervascularity, bronchial atresia, less likely as there was no focal bronchial dilatation. Now, what is CPAM? It is a developmental anomaly of the lower respiratory tract where an abnormal lung tissue develops instead of a normal lung tissue. Basically, it presents mostly after 16 weeks of gestation. CPAM volume ratio should be determined, and associated renal, cardiac, and tracheoesophageal fistulas should be looked for as it is seen in 10% of the cases. Now, in my case, the CPAM there are cysts type 2 where there are cysts less than 2 centimeter. In type 3 there are microcysts less than 5 mm, and basically the cysts are indistinguishable and the whole tissue looks like a solid abnormal lung mass. and type 4, where large cysts are there more than 10 centimeter. Now, basically, what is the risk of fetal hydrops and to guide us with the management options. It is nothing else but the volume of the CPAM divided by the fetal head circumference in centimeter. So, what does it imply? If the CPAM volume ratio is less than or equal to 1.2, it suggests a low risk for developing hydrops and a weekly ultrasound is recommended. If it is between 1.2 to 1.6, there is a moderate risk and twice weekly monitoring should be done. However, if the value is more than 1.6, there is high risk of developing hydrops or mass effect, and it is recommended that the follow-up should be done 2 to 3 times per week. So what it does, it helps stratify fetuses for expectant management versus intervention. Now, looking at the normal growth graph for CPAM, it usually starts growing in the early second trimester and plateaus throughout the second trimester. In third trimester, it has variable response. It can remain same in size or decrease in size and completely disappear in its third trimester. So we went ahead with a fetal MRI of the baby, and what did we confirmed the presence of the abnormal lung mass. However, we also saw stretched hilar vessels. So here, no differential was included, that is congenital lobar overinflation. So there was a regular follow-up with the patient as CVR ratio was 2.65 and there was polyhydramnios. However, no hydrops developed till the end, and the baby was delivered through normal vaginal delivery at 38 weeks of pregnancy. Post-birth, the baby developed tachypnea, followed by which X-ray chest was done. Now here you can clearly see that there is a hyper-expanded left lung with mediastinal shift towards right and a flattened left heavy diaphragm. We went ahead with a HRCT chest at day 4 of life, which also confirmed a hyperextended left upper lobe with normal pulmonary vessels traversing through it, and a compressed left lower lobe and right lung, thus clinching the diagnosis of congenital lobar overinflation. The patient underwent left upper lobectomy on day was confirmed as congenital lobar. It is bronchial
I mean, voice is breaking. If you can just switch off your camera. Dr. Revati, you can switch off your camera. Your voice is breaking.
Yes, sir, I switched it off.
So it will be better
No,
now present.
You switch off your camera just to do the presentation. Yeah.
Sir, I have switched it off. Sir, should I continue?
Yes, better now.
Yes. So most common site of CLO is left upper lobe. Hypervascularity may be an important imaging feature, and microvascular flow feature in your ultrasound system can be helpful. Now going on to the differential diagnosis. Basically, you should see whether the abnormality is bilateral or unilateral. If the abnormality is bilateral, then it is more central airway abnormality such as tracheal atresia or laryngeal atresia. If there is unilateral echogenic lung lesion, then look for the continuity of the diaphragm. If there is discontinuity, then the diagnosis is diaphragmatic hernia. If there is the continuity of the diaphragm is maintained, then go and look for the supply of the echogenic lung mass. If it is supplied by the aorta, then it is pulmonary sequestration. If it is supplied by the pulmonary artery, then all these three differentials should be considered as congenital lobar overinflation with stretched hilar vessels coursing through the echogenic lung, type 3 or microcystic variety of the CPAM, where there is absence of pulmonary artery, and bronchial atresia, where there is focal bronchial dilatation. Now, going through some cases, here as you can see, there is abnormal echogenic lung mass in the left lung, and on color flow, there was no pulmonary arteries coursing through it, clinching the diagnosis of CPAM microcystic variety. Here you can see that the abnormal echogenic lung tissue supplied by the aorta with features of hydrops. So this was pulmonary sequestration with features of hydrops. And this is a case of CDH or congenital diaphragmatic hernia, where you can see that the fundic bubble is at the level of 4 chamber. There is also discontinuity of the left hemidiaphragm, and the presence of intestine and the stomach bubble in the chest. So going to the management part, if the abnormality is bilateral, then the prognosis is poor and genetic testing should be performed, as more than 50% of the cases are associated with genetic abnormalities. However, if the abnormality is unilateral, it depends whether the fetus has hydrops or does not have hydrops. If the fetus has hydrops, then the prognosis is guarded, and your options are termination of pregnancy, thoracosynthesis, thoracoamniotic shunt for pleural effusion or larger cysts, and in pulmonary sequestration, coagulation of the feeding vessel. If the fetus is more than 32 weeks, early delivery should be considered. If the fetus does not have any hydrops, in cases of CDH, go for genetic testing, look for associated anomalies in CPAM and pulmonary sequestration. Monitoring is essential. In CPAM, look for CVR, and in cases of polyhydramnios, tapping should be done. So basically, my take-home message is think beyond CPAM. So if there is a unilateral hyperechoic lung lesion, look for a feeding vessel, systemic or pulmonary. Look for focal bronchial dilatation to to rule out bronchial atresia. Look for continuity of diaphragm to rule out CDH. Look for associated complications such as hydrops, associated anomalies. Counseling is very important, whether there is requirement of amniocentesis or not. And use of microvascular flow will help narrow down differentials. Monitoring is absolutely necessary. These are my references, and I thank you all for a patient hearing. Thank you so much.
Great. Brilliant. After that brilliant talk by Dr. Revati on echogenic lung lesions, let's go to the issues of monochorionic multiples, decisions and dilemmas, to be presented by Dr. Nishigandha Mali. She is a consultant fetal sonologist at Nauroji Wadia Hospital, Parel, and she was former clinical associate at Surya Child and Mother Hospital at Santa Cruz. So, Dr. Nishigandha, please. Thank you.
Is my screen visible?
Yeah.
Yes.
Good evening, everyone. I'm Dr. Nishigandha Mali, and at the outset, I'd like to thank everyone for this opportunity. Ashok Khurana sir, Mohit Shah sir, Shlok sir, and my guide and mentor, Dr. Vandana Bansal ma'am. So today I'll be talking about monochorionic multiples, decisions and dilemmas. So this is a story of two women with triplets and their unique problems and the different paths they chose. So the first case, she was a primary with IUI conception. Now she had a monochorionic triamniotic triplet gestation. She came to us at around 13 weeks. So as we can see here, there's one placenta and there were 3 separate amniotic membranes. Now all the 3 fetuses were essentially normal. All the CRLs were within normal limits. The nuchal translucency scans were normal. Now, this patient was very desirous of a singleton pregnancy only. So here the dilemma was how many to reduce. Do we reduce just one or no fetuses? But here then we are left with a very high risk of preterm delivery and monochorionicity complications. Or we go ahead with a reduction of 2 fetuses as the patient desires, but then we do have an increased chance of losing the entire pregnancy. So the decision, the couple chose to reduce 2 fetuses. Now, owing to the monochorionic gestation, we had to opt for interstitial laser reduction. And since all 3 were essentially normal looking, fetus B and C were reduced, and fetus A being nearest to the cervix was preserved. As per departmental protocol, on day 2, the fetus A was healthy, fetus B, C was cardiac apostole. She followed up with us for our anomaly scan. And here now we could not, at 19 weeks, we could not visualize the left kidney in the renal fossa. There was a suspicion of a pelvic kidney, and this was followed up and confirmed at 22 weeks. So she went on to deliver a term healthy neonate weighing 3.2 kg. Now the second case, who somehow came to us almost at the same time, was a primigravida with now an IVF conception. She had a dichorionic triamniotic pregnancy where fetus, here as we can see, A and B were a monochorionic pair and fetus C was separate. However, fetus C also had an absent nasal bone at the NT scan. Sorry, fetus C had an absent nasal bone. Now, so here we were faced with the dilemma of should we just reduce fetus C? There is already an absent nasal bone, but then we are left with a monochorionic pair. Or do we go ahead and reduce the monochorionic pair, but then we still have what about the absent nasal bone? So the decision reached here was to perform a chorionic villus sampling of all the fetuses. CVS was performed, and then the fish and karyotype reports were normal. And the decision reached here was then to perform an interfetal laser ablation of fetus B of the monochorionic pair. Essentially, then we have a dichorionic pregnancy continuing. The procedure went uneventful. The rest of her pregnancy also was uneventful. And she delivered at term at 36 weeks with she delivered healthy twins with normal birth weights. So as we know, 1/3 of all twins are monozygotic, and of these, almost 3/4 are monochorionic. And IVF increases the risk of monochorionic twins by 5 times. Now, this effect is even more pronounced in the case of a triplet gestation, where naturally occurring monochorionic triplets are extremely rare, but can increase by up to 100 times with ART. They come with their own set of complications, such as preterm labor, which can be as high as 80%, a longer hospital stay, lower birth weights, increased risk of stillbirth and neonatal deaths. In addition, now the complications of monochorionicity, as we're all aware, include selective fetal growth restriction, twin-to-twin transfusion, a single fetal demise, trapped fetus, and a discordant anomaly. Hence, we have methods to reduce fetuses in monochorionic pregnancies, which include interstitial laser ablation, fetoscopic bipolar cord occlusion, radiofrequency ablation, and limited use of intracardiac KCL if we're reducing a fetus with a separate placenta or choosing to reduce a monochorionic pair in triplets. So the advantage of fetal reduction in triplet gestation, it is observed that the more number of fetuses we reduce in a triplet gestation, there is definitely a higher chance of miscarriage. However, we do have a lower risk of preterm birth before 34 weeks. Essentially, we give a greater chance of a healthy take-home baby. So this was demonstrated by a study by Morlando et al., where if we take a look at this table on the right, the more number of fetuses you reduce, even in a TCTA gestation, you could almost half the preterm birth rate by reducing to 2 fetuses, and halve it further by reducing it to 1. And with dichorionic triplets, a similar effect was observed from reducing triplets to twins. However, these procedures are not without their complications. So Nicolais et al. Demonstrated in a cohort of 61 cases of interfetal laser reduction from dichorionic triamniotic triplets to dichorionic diamniotic twins, which was similar to a second case. They demonstrated that there is a very high risk of co-twin demise within 2 weeks to the tune of 45%. So the challenges of monochorionic reduction include limited use of intracardiac KCL, a very high possibility of sudden co-twin or co-triplet demise, which is up to 45%. There are also reports of aplasia cutis congenita in cases of interstitial laser, and of course, choosing which fetus to terminate at a very early gestation. To summarize, the complications of these procedures include miscarriage, sudden co-twin or co-triplet demise, and later in the pregnancy, preterm premature rupture of membranes, preterm labor, fetal growth restriction, and low birth weight. These are a few studies which have studied the risk of the complications. One study included DCTA triplets, which had a 3.3% risk of miscarriage and 8.5% risk of preterm birth. Another study by Morlando showed a very high risk of preterm delivery, but these used multiple methods. And a study which included twins and triplets, but RFA showed a high co-twin loss of around 20%. So to conclude, in the ART era, the risk of multiple pregnancies and monozygotic gestations is on the rise. They come with their own set of unique complications, which everybody working in fetal medicine and obstetrics must be well versed. There is a very delicate balance between choosing whether to reduce an uncomplicated pregnancy versus preparing to deal with the complications we may face in the future. And the most important thing is there is an absolute need of extensive evidence-based counseling, respecting the patient's wishes, and a frank discussion of all possible outcomes required to deal with these cases. Thank you. These are my references.
Brilliant, Doctor.
The number of monochorionic twins and triplets have increased so much now with the IVF. So I think we all as fetal medicine and as obstetricians will have lots of these monochorionics which will start coming. And the dilemma, like what Nishigandha presented, was not of just thinking ki we remove the monochorionic pair and leave the select one single fetus. Here there was a problem in one of the baby, the absent nasal bone in the second case, and all three were trichorionic in the first one. And that was a doctor patient, I think, and she wanted a singleton because she did not want preterm labor. So what you said, the patient's desire, but they need to be educated on the complications associated with it and the risk of the reduction as well. So these are procedures which have got very high risk and need to be done at tertiary centers. But yes, they are available. They are available in India. And with these monochorionic twins, we have got radio frequency ablation, microwave. Also now microwave is coming up, which is better than the laser and the RFA. And so I think we have lots to do in twins and monochorionic pairs. Shlok, you can take over from here.
Brilliant, madam. And congratulations for doing such a path-breaking work in the field of fetal medicine. Excellent. Now I would invite Dr. Harshita Shetty. She would be talking about Binder's facies. Dr. Harshita is a post-MD senior registrar at KEM Hospital and St. G.S. Medical College. So welcome, Dr. Harshita. Please share your slides.
Is my slide visible?
Not yet visible, Harshita.
Yes.
Yeah, now it is visible. Now go to a presentation mode.
Very good evening to everyone. I'm Dr. Harshita Shetty, Senior Resident in the Department of Radiology at KEM Hospital, Mumbai. I'm presenting this case under guidance of Dr. Himangini Thakkar ma'am, our head of the Department of Radiology. So let's go to today's case, when a face tells the story. A 30-year-old woman, gravida 2 para 1, who had a third-degree consanguineous marriage, came for a routine anomaly scan to us at 23 weeks of gestation. She had a previous child, a 5-year-old daughter, who was developmentally normal. There was no family history of any genetic disorders or any significant past medical history, and she did not have any history of drug intake or illness during the current pregnancy. The ultrasound examination showed that the fetus had a flat facial profile with relatively verticalized nasal bone and a relative prognathism, which is termed as binder facies. So objectively, this is measured by an angle which is called as a frontonasal angle. So frontonasal angle is derived by the intersection of two lines. One line is drawn from the top of the forehead up to the nasal bone, and another line is drawn from the nasal bone up to the nasal tip. So the frontonasal angle, which was measured in our fetus, came out to be 137 degrees. So the normal range of this frontonasal angle ranges between 119 degrees to 133 degrees between 14 to 39 weeks of gestational age. So the frontonasal angle was increased in our case, which signifies that there is a verticalized nasal bone. A 3D ultrasound was performed for better visualization of this abnormality, which confirmed our findings of a flat facial profile with a short verticalized nasal bone and relative prognathism. So what is this binder facies? It is a kind of a maxillofacial dysostosis, which was described by Binder in 1962, which consists of a facial profile with a short nose, flat nasal bridge, convex upper lip, high arched palate, and relative prognathism. So what are the etiologies of this binder facies? It is associated with phenytoin or warfarin exposure. It is associated with vitamin K deficiency. It is associated with systemic lupus erythematosus, skeletal dysplasias like chondrodysplasia punctata, and it can be an isolated type of binder type of nasomaxillary dysplasia. So in our patient, there was no history of any drug intake, ruling out phenytoin or warfarin exposure. She did not have any complaints of malabsorption or hyperemesis gravidarum suggesting vitamin K deficiency. There was no malar rash or photosensitivity to suggest SLE. So our next suspicion was, our next step was to rule out chondrodysplasia punctata. So we did a detailed skeletal survey for the fetus. So on performing ultrasound, we saw that the upper end of the femur did not have a single epiphysis, but there were multiple stippled areas of calcification, which was noted in place of the upper femoral epiphysis. On ultrasound examination of the foot revealed that there was ossification of the talus, cuboid, and calcaneum, the tarsal bones, which is abnormal at this gestational age of 23 weeks. So the normal foot bone ossification starts from 9 weeks, where there is ossification of the metatarsals at 9 weeks, followed by ossification of the phalanges starting from between 10 to 14 weeks. Followed by that, there is ossification of the tarsal bone in sequence at 24, 28, and 36 weeks. So at 23 weeks, none of the tarsal bones should have been ossified, which was not the thing which was in our case. So it is abnormal. On examination of the spine, we found that there is ossification of all the 5 sacral vertebrae, S1 to S5, which is again abnormal for the gestational age of 23 weeks. Also, we found that the coccyx was ossified. Normally, the coccyx ossifies at term. So this is abnormal at 23 weeks. So let us look at the normal sacrococcygeal ossification. The L5 vertebral body ossifies at 16 weeks, S1 ossifies at 19 weeks, and there is progressive ossification from S1 to S5 between 19 to 27 weeks. And the coccyx does not ossify till term. So at our gestational age of 23 weeks, only the first 2 sacral vertebrae should have been ossified, but all of them were ossified, which was again abnormal. We performed a 3D ultrasound on this fetus, which confirmed our findings of ossification of the sacrum as well as the coccyx. So we concluded that this is the diagnosis of chondrodysplasia punctata. And in order to rule out any underlying genetic abnormalities, we performed an amniocentesis, and a QF-PCR test came out to be negative, that ruling out trisomy 21, 18, and 13. The patient was counseled regarding the prognosis of the skeletal dysplasia, and she opted to undergo a medical termination of pregnancy. Examination of the abortus confirmed our findings of a flat facial profile with a depressed small nasal bone, and there is relative prognathism. So it corresponds to our 3D ultrasound findings of a small nasal bone and a flat facial profile. A skeletal survey was performed on the abortus, which shows that there is calcific stippling noted at the upper end of the femur. Also, there is ossification of S1 to S5 vertebral bodies. The skull shows verticalized nasal bone, and there is midfacial hypoplasia. Also, examination of the foot shows that there is stippling noted at the in the tarsal bones. So this confirms chondrodysplasia punctata. So what exactly is this? It is a radiological diagnosis, not a disease in itself, and it comprises of a group of skeletal dysplasias, and all of them are characterized by calcific stippling of the cartilage and the periarticular soft tissues. There is rhizomelic or short limb dwarfism. There is facial dysmorphism, which is binder's faces with maxillonasal hypoplasia and spinal abnormalities. It is also associated with skin lesions and cardiac malformations. And chondrodysplasia punctata has different etiologies, and they are grouped into the following 3 categories. So group 1 consists of the abnormalities in peroxisomal function or cholesterol biosynthesis, and all of them are lethal types of chondrodysplasia, which is a rhizomelic type of chondrodysplasia, or that associated with Zellweger syndrome and Conradi-Hanemann syndrome. Group B consists of the abnormalities of vitamin K metabolism. So it can be because of warfarin embryopathy, fetal phenytoin exposure, or maternal vitamin K deficiency. And group 3 consists of chromosomal abnormalities, which is trisomy 21 and trisomy 18. So is a flat facial profile or binder facies an indication for MTP? The answer is no. because binder facies can also be an isolated abnormality, as we saw in the etiologies. However, this should always be a diagnosis of exclusion after we look at the medical history, ruling out exposure to warfarin or phenytoin, after we perform a detailed skeletal ultrasound for the fetus, and we rule out chondrodysplasia punctata, and we also rule out chromosomal abnormalities like Down syndrome. Only after that we can say that this binder facies is an isolated abnormality, and there are multiple case reports in which fetuses with a flat facial profile are doing well, though we need to monitor the fetal growth and liquor, because these fetuses can have a problem with swallowing of the amniotic fluid, which can cause polyhydramnios. So to take home, we can say that binder facies can be an isolated abnormality. It is not an indication for termination, medical termination of pregnancy in itself. However, because it is associated with chondrodysplasia punctata and chromosomal abnormalities, we need to do a detailed skeletal system evaluation for the fetus, a detailed cardiac evaluation for the fetus, and we need to rule out any associated abnormalities. Also, invasive testing is recommended. A karyotyping, a chromosomal microarray, and whole exome sequencing is needed in order to rule out any underlying genetic disorders. These are my references. Thank you very much for the patient listening.
Excellent presentation, Dr. Harshita, on Binder's facies. Now we will take a short break for presentation of the trade partner video. Also, at the end of the entire session, we would be having a detailed question answer session. So stay back with us. Great. So there are so many reasons to be member of Society of Fetal Medicine. Now we would start our presentations again. I would invite Dr. Shraddha Gawan to present her talk on placental masses. Dr. Shraddha works as a consultant at Thane Ultrasound Center of Dr. Nitin Chaubal. Welcome, Dr. Shraddha. Kindly share your slides.
Good evening, everyone. I'm Dr. Shraddha Gawan. I'd like to thank Society of Fetal Medicine for allowing me to present my case. I will also like to thank Vandana Balsan ma'am, Alok sir, and Shlok Lolge sir. My case is placental mass. My patient was 25-year-old female. She was gravida 1, para 0, with a history of non-consanguineous marriage. She came to us at 30 weeks of gestation. NT scan and anomaly scan done elsewhere was unremarkable. On examination, we found polyhydramnias. Maximum vertical pocket was 12.6 centimeters. You can see in this slides, the maximum vertical pocket is 12.6 centimeter. On detailed examination for the cause of polyhydramnias, we came across a finding of a well-defined hypoechoic mass on the fetal side of the placenta, which was measuring approximately 53 mm into 47 mm. On further evaluation, the MCA PSV was 75 centimeter per second, which corresponds to the 1.8 MOM, which was high. The myocardial performance index was 47%. So this is a hypoechoic mass, which is well defined, well circumscribed, measuring 53 mm into 47. This is the vascularity within the mass. You can see the slide of the vascularity within the mass, and this is the 3D construction of the vascularity within the mass. So this is a MCA PSV, which was 75 centimeter per second, corresponding to 1.8, which is high. The myocardial performance is 47%. So we came to the diagnosis of placental chorioangioma with a polyhydramnias with fetal anemia and cardiac overload. So the placental chorioangioma, it is a benign vascular placental tumor. It is usually located on the fetal side of the placenta near the cord insertion. It is majority of the placental chorioangioma are small, microscopic, and can be missed. If the lesions are more than 5 centimeter, more likely to be diagnosed prenatally. On ultrasound, on grayscale, these masses are well-defined, well-circumscribed masses, predominantly hypoechoic, but these can be heterogeneous because of the hemorrhage or infarction. On color Doppler, the amount of flow in the mass is quite variable. If the arterial flow, if there is an arterial flow, then it increases the risk of developing the hydrops. Clinically, usually it is presented incidentally. It can present as a fetal anemia due to the hemolysis. It can present as an increased serum alpha fetoprotein because of the maternal hemorrhage or fetal hemorrhage. It can also present as a polyhydramnios as the fluid may transited from the leaky tumor vessels. It can also present as a fetal hydrops. It may be due to the arteriovenous shunting, or it can be due secondary to the fetal anemia. The patient may present with a fetal growth restriction because of the non-functional placenta, and it can present as a preterm labor due to the polyhydramnios. Rarely the mass, it may present as a preeclampsia. The differential diagnosis are venous leaks, submucosal fibroid, but the submucosal fibroid will be on maternal aspect. It will have a peripheral vascularity. The other differential diagnosis is the placental hemorrhage. It does not reveal any vascularity, and it will change in appearance as the time progresses. It can present the other differential diagnosis is gestational trophoblastic disease, but it will be a diffuse disease with the cystic changes in the placenta. Prognosis. It has an excellent prognosis if there is no hydrops. Most of the cases are small, which do not need treatment, but we have to follow it up every 2 to 3 weeks for increase in the size of the mass, increase in the vascularity of the mass, or the fetal assessment for the development of the anemia, polyhydramnios, fetal hydrops, or fetal growth restriction. If the masses are large, then we should look for the complication, which may need a treatment according to the presentation. If it presents with a polyhydramnia, we should consider for the amnioreduction. If it presents with a fetal anemia, transfusion should be considered. Other methods of treatments are vessel ligation, laser coagulation. In our center, the patient was treated with a histocryl glue with a lipidol. So, histocryl glue is an embolic agent used in interventional radiology used to treat the placental choreangioma by embolizing the feeding vessel, effectively cutting off the blood supply to the tumor. It is very minimal invasive procedure. Under the ultrasound guidance, the feeder vessel is identified and the spinal needle is carefully inserted into the target vessel. The mixture of histocryl glue diluted with a lipidol is injected into the vessel. This stops the blood supply to the choreangioma up, okay? And the after procedure, we should confirm the absence of blood flow to the tumor. Other methods of treatment are the radiofrequency ablation, that is a RFA. It is a technique used to treat the large placental choreangioma with the complications like fetal anemia, hydrops, and heart failure. Under the ultrasound guidance, the needle-like electrode is inserted into the tumor to deliver the radiofrequency energy. Heat generated by the radiofrequency waves shrinks the tumor tissue, effectively reducing the size of the lesion. This is the procedure which was conducted in our center. You can see the spinal needle is entered into the placental choreangioma. This one is the other slide. 1.5 ml of glue with a 4.5 ml of the lipidol was injected. We can see the glue entering into the placental choreangioma. So post-embolization, we come across the reduced vascularity. And after follow-up, after two weeks, there was no internal vascularity in the mass, and the MCA PSV was 58 centimeter per second, which was corresponding to the 1.3 MOM. This is the healthy baby delivered at a term with a normal hemoglobin. And these are the other cases which we come across in our center. You can have a look at. This is a hypoechoic mass on the fetal end of the placenta, which was measuring approximately 54 into 29 with a variable amount of the vascularity. This one is revealing the mild vascularity. The other cases are like this. This one is revealing the significant vascularity. Thank you so much for plus.
Wow, brilliant. Great case, brilliant images, Shraddha, and a novel way to treat chorioangiomas, placental chorioangiomas. I would invite now Dr. Rucha Shingnapurkar to present her talk on cystic fibrosis. Dr. Rucha is a fetal medicine fellow at Surya Hospital. Dr. Rucha, kindly share your slides.
Good evening. I'm Dr. Rucha Shingnapurkar, and I would like to thank SFM, Dr. Ashok Khurana sir, Shlok sir, Alok sir, and my mentor, Dr. Vandana Bansal ma'am, for this opportunity. So today I will be presenting a case on prenatal diagnosis of cystic fibrosis with echogenic bowel and dilated bowel as diagnostic clues. So talking about echogenic bowel, it is defined as echogenicity equal to or greater than that of the fetal bone, typically compared to that of the iliac wing, with a prevalence of 0.2 to 1.8% of all pregnancies. It could be a diffuse or a focal finding. It is a soft marker for chromosomal abnormalities with a likelihood ratio of 1.6. So the diagnosis should always be confirmed by using a lower frequency transducer, less than 5 megahertz, and by turning down the gain settings until other soft tissues are no longer visible and only bone or bowel is visible. In literature, there are grades mentioned for echogenic bowel. Well, grade 1 is echogenicity increased but less than that of the iliac crest. Grade 2, echogenicity similar to that of the iliac crest. And grade 3 is echogenicity greater than that of the iliac crest. Though this classification is not that commonly followed. So coming to differential diagnosis for echogenic bowel, there is congenital intrauterine infections, cytomegalovirus, toxoplasmosis, chromosome anomalies like trisomy 21, growth-restricted fetuses, intraamniotic bleed, bowel pathology, and cystic fibrosis. So dilated bowel loop is characterized by abnormal enlargement of fetal intestinal loops, defined as loops that are greater than 7 mm in diameter and or 15 mm in length. And this usually indicates any kind of mechanical or functional bowel obstruction. So for a quick recall, we can remember 8 mm and 18 mm respectively as cutoff for small bowel and large bowel on ultrasound. Again, differential diagnosis for for dilated bowel are meconium ileus, cystic fibrosis seen in up to 10% of cases, intestinal atresia, anorectal malformations, infectious diseases like cytomegalovirus, aneuploidies, Hirschsprung's disease, and volvulus. Coming to my case report, she is a 26-year-old married in a non-consanguineous marriage with a previous healthy male child, 4 years old, and she presented to our facility at 21 weeks gestation with an outside scan showing echogenic bowel. Her first trimester screening was normal. So ultrasound scan at our facility revealed echogenic bowel with 2 additional findings of dilated bowel loop measuring 29 into 17 mm in length and 5 mm in diameter, along with non-visualization of gallbladder. No other soft markers were identified. So normally, gallbladder is in fetal life is can be visualized from 15 to 16 weeks of gestation as an anechoic pear-shaped structured in the right upper abdomen below the liver and to the right of the stomach. According to the ISIOC 2022 mid-trimester guidelines, it is a part of a standard checklist, but complete assessment of gallbladder is optional. It is a strong, when non-visualized, it is a strong prenatal marker for cystic fibrosis when combined with bowel findings. And in case of non-visualization, the scan should be repeated after 1 week. So in most of the cases, it is a transient finding. Some are due to isolated gallbladder agenesis in 5% of cases associated with cystic fibrosis and rarely biliary atresia. It could be a normal variant as well. So this is a study. This is a slide showing results of study, which is a systemic review of literature on outcome of non-visualization of gallbladder on second trimester ultrasound, where they have seen that isolated non-visualized gallbladder was later visualized in pregnancy in 70% of cases, followed by agenesis in 25%. And still associated with cystic fibrosis in 3% of cases. When seen with associated anomalies, there was a higher risk of cystic fibrosis, uh, followed by also risk for chromosomal anomalies and risk for biliary atresia. So in our case, looking at these multiple findings, there was a high suspicion of a genetic disorder. We counseled the patient. Amniocentesis was done for her, and sample was sent for FISH, TORCH, PCR, microarray, whole exome sequencing. So FISH report, TORCH PCR report, and microarray report, as we can see, are all normal. Her whole exome report revealed cystic fibrosis, homozygous CFTR gene mutation consistent with an autosomal recessive inheritance pattern. So by this time, she was in her 25th week of gestation, and a couple wanted to continue with their pregnancy. A scan was later done at 25 weeks showing dilated echogenic bowel, measuring 54 mm in length and 9 mm in diameter. Consistent finding of non-visualized gallbladder was noted and now was associated with polyhydramnios. Multidisciplinary counseling was done. Need for lifelong management of cystic fibrosis was explained. Pregnancy was continued. She delivered a male child, 2.4 kg weight at 36 weeks, operated on day 4 for intestinal obstruction. And as of today, the baby is 7 months old, requiring empirical chest physiotherapy with intermittent nebulization. So cystic fibrosis is a monogenic autosomal recessive disorder. It is a multisystemic disorder affecting respiratory, digestive, and reproductive system caused by mutation in the CFTR gene located on chromosome 7. Global incidence is 1 in 3,300 live births. In India, it is 1 in 40,000 live births, but the carrier frequency is quite high, which is 1 in 30. So mutation in CFTR gene impairs the chloride ion transport in cells lining lung, pancreas, causing altered secretions, blocking their ducts, infection and inflammation, finally causing full-blown cystic fibrosis, which causes a bacterial airway and sinus infection, pancreatic exocrine deficiency, male infertility, female infertility. Life expectancy of these individuals, global expectancy is 50 to 57 years. Indian life expectancy is quite lower, although early diagnosis and CFTR modulators are crucial for better outcomes. So now there are multiple studies in literature where they have compared antenatal ultrasound findings to that of postnatal diagnosis of cystic fibrosis, where they have said that echogenic bowel is most predictive of cystic fibrosis and has been reported in 1 to 13% of these fetuses. And when combined with additional findings like dilated bowel, the risk increases to 17 to 20%. So I would like to conclude by saying that echogenic bowel on prenatal ultrasound warrants thorough evaluation. Although aneuploidies is common, but rare etiologies like cystic fibrosis must be considered. And other structures, especially the heart, GI system, urinary system, should be carefully examined when non-visualized gallbladder is suspected. Thank you.
So excellent, Dr. Rucha, the presentation. The take home from this is when you see an echogenic bowel, we are thinking of infections, we are looking at aneuploidy risk of 1.6 likelihood ratio. But if I see something more, if I see a gallbladder absent, then you start thinking of cystic fibrosis. So alone echogenic bowel, maybe we would not put in a needle to test, but if I see something else like an absent gallbladder, then the chance is very high of cystic fibrosis. So I think Shlok, we can
Great.
go
Yeah.
ahead with that.
Thanks, Dr. Richa, for an excellent presentation. And you have covered all the aspects of cystic fibrosis. Great. Now I would invite Dr. Rupali Bansal to present a talk on size does matter. So she's going to talk about that. And Dr. Rupali is working as a consultant at Leelavati Hospital, Mumbai, and has done a fellowship in ultrasound and color Doppler at KEM Hospital and GS Medical College. Welcome, Dr. Rupali.
So am I audible?
Yes, Rupali.
Okay. And my screen is also visible, right?
Yes,
Okay.
absolutely.
Before I start, I just want to thank Dr. Hemangini Thakkar ma'am, Alok Vaishni sir, Shlok Lolge sir, and Vandana Bansal ma'am. My topic for today is size does matter, small size, big implications. Let's dive right into the first case. A 23-year-old normotensive lady came for the first consultation to our hospital at 22 weeks of gestation. She had a history of one spontaneous abortion at 2 months, for which no DNC or further testing had been done. A 6 weeks dating scan done elsewhere was available, in which the gestational age by LMP and as well as by CRL was corresponding. First trimester anomaly scan had not been performed. Second trimester anomaly scan done elsewhere at 18 weeks was reported as normal. A detailed second trimester anomaly scan done by us at 22 weeks showed no gross structural anomalies, but the biometry looked like this. As we can see, all the percentiles are falling in the shorter range. So, what do you do when all the parameters in a second trimester fetus are smaller than expected? The first thing we did was review the dating scan. Was the section of the CRL not taken correctly? But that wasn't the case. Next, we reviewed the 18-week scan. The fetal growth was lagging by 1 week at that time. The EFW and AC were at the 10th centile and Doppler was not performed. In the current scan, the growth corresponded to 22 weeks, 5 days by LMP as well as by dating scan, but by biometry corresponded to only 21 weeks, 1 day, with an EFW falling at the second percentile range. As we can see here, everything was falling in the less than -2 standard deviations mark. Next, we performed the Doppler parameters. Umbilical artery showed a positive diastolic flow with PI at the 70th percentile, CPR at the 13th percentile, and mean uterine arteries at the 75th percentile. The TCD as well as all the other parameters, including other long bones, were also small for gestational age. Placenta was unremarkable, amniotic fluid adequate, so the final diagnosis given was early onset FGR stage 1. Around a month later, we were faced with another similar dilemma. A 24-year-old non-consanguineously married normotensive lady came for her second trimester anomaly scan. She had a bad obstetric history with 2 previous IUFDs in the 7th month, cause unknown, and a live daughter of 5 years who was a known case of congenital heart disease and a small left multicystic dysplastic kidney. In the current pregnancy, the course had been uneventful so far. No dating scan had been done, but a first trimester anomaly scan done elsewhere was normal. The second trimester anomaly scan done by us revealed mild oligohydramnios, likely thymic hypoplasia, no other structural anomalies, normal placenta, and normal Doppler parameters. However, the biometry told a different story. As we can see here, all the parameters are falling in less than 0.1 percentile range. The gestational age by CRL from the NT scan as well as by LMP was 20 weeks, 6 days. However, by biometry was only 17 weeks, 1 day, with an EFW falling in less than 0.1 percentile range. So final diagnosis given once again was early onset FGR stage 1. Since both the cases were found in normotensive mothers with the fetus showing no structural anomalies, we approached them in a similar way, that is, to rule out various causes of early onset FGR step by step. So what are the causes of early onset FGR? They include placental, maternal, fetal causes and others. Let's start with the maternal causes. They include chronic diseases like preeclampsia, hypertension, diabetes, renal disease, autoimmune disorders, vascular diseases, thyroid, etc. and lifestyle factors like malnutrition, smoking, substance abuse, alcohol intake, etc. Next, we come to the placental causes. As we all know, this includes the spectrum of maternal vascular malperfusion, where the abnormal trophoblastic invasion of spiral arteries causes high resistance, low flow circulation. Next, we come to the other causes, which include uterine causes like septate uterus, umbilical cord anomalies like velamentous cord insertions, single umbilical artery, and multiple gestations or ARTs. Since all these factors had already been ruled out in the 2 cases, we came to the next cause, which is the fetal causes. They include chromosomal and genetic abnormalities like trisomy 13, 18, 21, triploidy, and inborn errors of metabolism or fetal structural anomalies. And then, of course, we have torch infections, which can either directly affect the fetal cell growth
or the placental function. So, amniocentesis was performed in both the cases. In the first case, torch PCR came out to be negative, but shockingly, the FISH test came out to be positive for trisomy of sex chromosome. Trisomy of sex chromosome refers to 3 copies of a sex chromosome instead of the usual 2. The most common examples are XXX in females, Klinefelter's or XXY in males, and Jacob's or XYY also in males. These are generally less severe than trisomies of autosomal chromosomes. The prevalence is around 1 in 1,000 females and 1 in 500 males. Physically, they may be taller or have features like clinodactyly, and they can have mild symptoms like developmental delays, learning disabilities, motor and speech problems, hypotonia, behavioral and emotional problems, seizures, as well as kidney abnormalities. In the second case, we were surprised to find another positive report. A deletion of 849 kilobase pairs was noted on chromosome number 22, and this was likely pathogenic. There was an approximately total of 22 genes that were deleted, and this is the list of the genes that were deleted. One of the deleted genes was LZTR1, which is responsible for Noonan syndrome, and also known to cause behavioral and psychiatric problems, intellectual and learning disability, and autistic spectrum disorders, also reported to cause non-immune hydrops fetalis. The observed CNV also overlapped with 22q11 deletion, which probably explains the thymic hypoplasia. Another variation noted was actually categorized under variation of unknown significance, but the fetus showed homozygosity for this gene. And this variant can potentially cause alpha thalassemia, intellectual disability, hypotonic facies, and sometimes even hydrops. We think that this may explain the previous 2 IUFTs, but since it is classified as VOUS, we cannot really be sure. The final outcome, in the first case, the patient chose to terminate her pregnancy, while in the second case, she decided to continue it due to religious constraints. But IUFD occurred at around 29 to 30 weeks. So, these cases prove to us that sometimes chromosomal abnormalities may present as just early onset FGR and no significant structural anomalies. See, we usually tend to perform invasive tests anyway if there is either a structural anomaly or a history of a known genetic condition, or one of the screening tests like dual marker or NIPT is showing high risk for trisomy. However, these 2 cases are here to show us that that's not enough. So, I would like to stress upon 4 important take-home messages. The first one is that dating scan is extremely important. If the CRL measurement is not taken properly, all the future scans risk being termed as either FGR or SGA or LGA. Since if and when the LMP will not coincide with the biometry, we'll always go running to the dating scan for help. So, a good sagittal section of the fetus should be taken and preferably always do TVS. Secondly, we see residents do this really often. Do not round off the biometry to adjust to the calculated gestational age. Take the actual measurements and take it in standard sections, because sometimes the biometry may be giving us a very important clue, and sometimes that may be the only clue. Thirdly, use growth curves and percentiles. And fourthly, unexplained early FGR warrants an invasive testing after all the other factors have been ruled out. These are my references. Thank you.
Thank you, Dr. Rupali. A very important point to be remembered that there could be a genetic cause for growth restriction. Excellent. Now I would invite our final presenter, Dr. Sujal Mehta. She is a clinical associate in fetal medicine at Surya Fetal Medicine Center. Dr. Sujal is going to talk about sacrococcygeal teratoma. So welcome, Dr. Sujal. Kindly share your slides.
Good evening, everyone. Myself, Dr. Sujal Mehta. I have completed my MUHS fellowship and ICOG certificate course in fetal medicine under guidance of Dr. Vandana Bansal Madam. I am currently working as clinical associate in fetal medicine at Surya Hospital, Mumbai. Today, I am presenting a case of sacrococcygeal teratoma. So our patient was 31-year-old primi gravida, married since 2 years of non-consanguineous marriage with 34 plus 6 weeks of gestation, referred in view of mass arising beyond coccyx. It was a spontaneous conception. First trimester screening, Prader-Willi marker test and anomaly scan was not done. Detailed scan along with color Doppler was done, and it suggested single live intrauterine pregnancy of 35 weeks, AGA fetus, adequate Liker and normal Doppler waveforms with a 7.9 into 5.9 into 6.3 centimeter mass arising beyond coccyx with low vascularity seen in the mass. Generally, on ultrasound, teratomas appear as large masses arising from sacrococcygeal region, with some lesions predominantly cystic and little vascular, while some lesions largely solid and vascular. In our fetus, no signs of hydrops were seen. Brain, spine, spinal cord were normal. Tethering of spinal cord was not seen. Heart, kidneys, stomach, bladder were normal. Rest investigations were within normal limits. Delivery was planned at 38 weeks. Pediatric surgery team was informed and repeat Doppler was advised after 2 weeks. Pediatric surgery opinion taken. They advised tertiary center delivery, watch for hydrops. Baby will need early surgical intervention, NICU and ventilator to be kept ready. Repeat scan after 2 weeks suggested mild polyhydramnios with normal Doppler waveforms. No signs of hydrops were seen. Cardiac assessment was normal. Middle cerebral artery peak systolic velocity was normal. Emergency LACS was done at 38 weeks in view of premature rupture of membrane and sacrococcygeal teratoma. Female baby weighing 3.1 kilograms delivered. Baby was shifted to NICU for further management. Images show newborn with large sacrococcygeal teratoma before surgery. In NICU, baby was examined. Anal opening was patent. Baby passed meconium. Swelling in sacrococcygeal area measuring 8 by 6 centimeters covered by skin. USG skull was normal. USG spine suggested a large cystic mass arising from sacrococcygeal region with 3 masses joined together. No evidence of connection of mass with spinal canal was seen. 2D echo was normal. Baby was shifted to pediatric surgery unit for surgical intervention. Excision of teratoma was done and it was sent for histopathological examination. Histopathology suggested major teratoma of sacrococcygeal region. These were the immediate results after surgery. So, sacrococcygeal teratomas represent most common group of fetal tumors. Though prevalence is low, mostly female fetuses are affected. It is a neoplasm which arises from pluripotent cells of Hansen's node, which is located anterior to coccyx. They are classified according to Altman's classification, which is based on anatomical location. So type 1 are predominantly external with small internal components. Type 2 are dumbbell-shaped tumor with similar internal and external component. Type 3 are predominantly internal with smaller external components, and type 4 are exclusively internal, that is intrapelvic tumor. Our case was type 1, predominantly external. This classification is important for its prognostic value. Most teratomas are type 1 and type 2, which account for more than 80% cases, and less than 10% cases are of type 4. Type 4 has got highest malignancy risk. Though ultrasound helps in diagnosis of teratoma, but MRI helps in assessment of presence of internal component to determine whether there is any intrapelvic, intra-abdominal, intraspinal extension, whether there is any compression of adjacent organs like ureter, bowel, bladder. Complications are frequently associated with solid and large tumors because of shunting of blood from placenta to tumor, resulting in fetal anemia, development of high output cardiac failure, and polyhydramnios. Cardiac failure further induces placentomegaly, fetal hydrops, preeclampsia, and maternal mirror syndrome. Our fetus didn't have any of these complications. Differential diagnosis includes meningomyelocele and lipoma. In sacrococcygeal teratoma, spine is normal with no tethering of spinal cord, whereas in meningomyelocele, spine is abnormal with tethering of spinal cord. Further, in meningomyelocele, there is scalloping of frontal bones, that is Lemon sign, with obliteration of cisterna magna and abnormal anterior curvature of cerebellar hemispheres, that is Arnold-Chiari type 2 malformation. Sacrococcygeal teratoma originates from coccyx, whereas lipoma is associated with lower spinal elements and not coccyx. Obstetric complications include polyhydramnios, preterm delivery, preeclampsia, gestational diabetes, HELP syndrome, dystocia. Delivery should take place in tertiary referral center, and cesarean section is indicated in case of solid and large tumors due to high risk of soft tissue dystocia. Overall prognosis is guarded with 30 to 40% neonatal mortality rate. Indicators of good outcome are small cystic tumors. Prenatal indicators associated with poor outcome are tumor size more than 10 centimeter, tumor rupture, fracture of solid tumor component, increased vascularity, tumor volume growth rate more than 150 cc per week, prematurity, and TFR ratio. Tumor volume to fetal weight ratio more than 0.12 by 24 weeks of gestation is associated with poor outcome. Prenatally, ultrasound-guided interventions like radiofrequency ablation, laser coagulation, embolization to interrupt blood supply of teratoma have been attempted, but they are associated with poor outcomes. Postnatally, complete surgical resection, including coccygeectomy within first 2 months of life, is ideal treatment. Complete excision is sufficient even for tumors containing immature and malignant elements. Tumor is benign in neonatal period, but delayed surgery and incomplete excision can result in malignant transformation. Difficult surgery, especially for tumors extending in pelvis and abdomen, can result in nerve injury and incontinence. Chemotherapy is required as rescue therapy for those with recurrence and metastasis. Survival rates following complete excision is 100% even for malignant disease. So, finally, I conclude. Always differentiate between sacrococcygeal teratoma and meningomyelocele, as later one is associated with poor prognosis. Delivery in sacrococcygeal teratoma requires a multidisciplinary approach. Though ultrasound helps in diagnosis of sacrococcygeal teratoma, but MRI will help in assessment of pelvic extension. Thank you.
Sujal, I think you have missed your postnatal slide of the baby. Can you go back and show that? The image
Yes,
of the post-surgery baby. Go back in your slides. Go back to your surgery. Yeah, I was missing this. The next, no, that
No, previous one.
the baby,
yes.
baby surgery.
Yeah,
The next
the
one. The next one.
the suture marks.
The
Yeah,
sutures.
just to show how that huge tumor was managed and the buttocks of the baby after surgery. Dr. Alok, I just wanted you to see this image
Yes.
and appreciate, because I think she missed it during her presentation.
No, it was there. It was there.
Mhm.
You could see it.
Mhm.
So today has
Excellent.
been yes, a very, very nice, excellent presentations by everyone. Congratulations. You know, this SFM, this is a flagship academic program of SFM, and it promotes young presenters on a national platform. And even today, 350 delegates had joined at one time. And our presenters, they have kept everyone riveted with their crisp presentations on such rare abnormalities. And to top it up, we actually finished before time. So Khurana sir must be very happy.
Absolutely.
Yes, so we
Mohit sir.
finished a few minutes before time. It shows us that even in 8 minutes, so much can be told.
Yeah.
So hats off to all the presenters and hats off to their mentors. Thank you so much. And it gives us a few minutes more for the question answers. So let's go straight to the question answers. I expect all the presenters to answer those questions which are there in the chat box. Dr.
Alok, can I come in for a minute?
Yes, please.
Alok, I especially want to come in for a minute because this is something
yes,
I always
Mohit sir.
wanted. I always wanted for Mumbai. And I used to feel that Mumbai somehow is not being projected when we have so many young guns with us. Unfortunately, we couldn't just formulate a team who could, showcase their cases. But I want to congratulate all of them today. They did a marvelous job, absolutely wonderful job. I know most of them personally, but then I just want to congratulate them for their content as well as their delivery. Both were excellent, and I hope they continue this streak. I want to see more and more presentations. We have so many young guns, so many and young enthusiasts who are willing to participate. They just needed a platform. So I thank you for mentoring this, but I also want to thank Shlok and Vandana for taking this step. I was so wanting a Mumbai representation, and they came with a bang. Wonderful cases. All of you, congratulations. Well done.
Thank you. Thank you, ma'am.
Thank you, Mohit sir. Khurana sir, you are also there online, so I would like a comment from you as well, please. Thank you.
I am just so pleased. We have so much talent within the country, and every time I have to choose foreign faculty for an international conference, and I see programs like this, I wonder, maybe I should choose this. Because there is just so much learning we are now doing from case presentations, week after week, month after month, and year after year, that in fact, this seems to be the best way to get messages into our own heads. And I think that this discovery of yours, Alok, was really phenomenal. That let's get young people to present, get used to it. And today, each one of them has displayed a maturity that is way beyond what we expect with anybody who, some of them are first timers. And so this is absolutely phenomenal. And I'd like to congratulate the entire Mumbai team for putting this together. We're constantly looking to engage people, and it was so nice to see that we had so many presenters. We had to extend the time, and very happily so, because this was really so well attended. There was at no time anybody anywhere that was less than 320, which I thought was really, really fantastic. And I so look forward to increasing the frequency of these programs so that we can double our learning, triple our learning, and have those messages stick in our head. And congratulations once again.
Thank you very
Thank
much,
you,
sir.
sir, for
Thank you,
giving
sir.
us
Thank
this
you.
platform. That is how they all can present, because the platform is being given by SFM. So more
Right.
and more people can join in and learn from the Society of Fetal Medicine, sir.
Yes, we're all learning from each other.
Yes, sir.
So, Dr. Vandana and Shlok, can we go to the questions which are there in the chat box?
Yeah, I'll take the first question. Arthrogryposis, can it be detected in the first trimester? So, Dr. Lakshmi, would you want to answer this?
Yes, sir. Yes, definitely it can be diagnosed in first trimester as early as from 12 weeks of gestation. We can see increased nuptial translucency, and also sometimes in lethal cases we can see cystic hygroma. But along with that, there would be absent fetal movements. So yes, it can be diagnosed in first trimester of pregnancy.
Right.
Yeah, but we need to remember that not all cases of arthrogryposis can be
Yes,
diagnosed
yes,
in
sir.
the first trimester. There are certain myopathies which are going to present only in the second or the third trimester. Okay, so not everything can be diagnosed in the first trimester. We need to remember this.
The next question is, Dr. Revati, can
Khurana
you
sir
answer
wants to
this?
say something.
Yeah,
Yeah,
sorry, I
please.
was going to mention, I think this question was really asked from a medical legal point of view, that very often arthrogryposis is a delayed manifestation of a disorder of the CNS, etc., or even within the skeletal system. And the manifestations may not be there in the first trimester. So although in severe forms and in some forms, we can make a first trimester diagnosis, there would be a large number where we would diagnose them only in the third trimester. So that is really the perspective that we need to look at when this question is asked.
True, true.
Okay.
Wise words of wisdom. Excellent. Dr. Revati, can you answer this question? In a large CPAM with mediastinal shift, but no eye drops, how do Doppler changes in pulmonary artery predict fetal compromise?
Yes, sir. So basically, I have not seen fetal pulmonary artery Doppler parameters used in CPAM to look for prognosis. However, in general, the fetal pulmonary artery acceleration time upon ejection time can be used to look for lung maturity in the late third trimester, and the cutoff being 0.30. If basically the value is less than 0.30, then it indicates that the lung is not mature, and some post procedural intervention might be needed.
Okay.
And
And how does
if seniors know, they can highlight more
Yeah,
on
so
this.
basically, the prognostic factors are only size based. We do not actually use pulmonary artery Doppler for prognostication, because in any case, in fetal circulation, there is high resistance flow in the pulmonary artery. There have been some studies in postnatal cases where they have tried to identify pulmonary hypertension with lung lesions by using pulmonary artery Doppler, but that does not apply that well to the prenatal cases. Okay, so that's not very useful in the according to me.
Dr. Revati, how does the management and counseling differ in CPAM type 3 and in CLO?
Yes, sir. Sir, in CPAM type 3, basically in CPAM, the risk of hydrops is more, especially with increased sizes. That's why CPAM volume ratio is always calculated. And in CLO, the risk of hydrops is low. That's why it differs in monitoring and management.
Right. Dr. Bansal?
Additionally, the CPAM may resolve, but a CLO may not resolve. So you need to follow both of them. The CPAM has got a better prognosis. So you can tell them that the third trimester, it may come down also, but CLO may not come down. But it's very difficult to differentiate CPAM from CLO on ultrasound itself. I think for your case also, the MRI was clinching the diagnosis, because that huge lung was there in your CPAM, in your case, and you did an MRI which showed the
Stretched vessel sign, yeah.
the stretched vessel
Right.
sign.
Vessel
So,
sign. True.
Alok, you can add on to that maybe.
Absolutely correct. I simply club them all together. White lung lesions. Because it's antenatally, sometimes it is very difficult to distinguish between one type from the other. And even let's say if you want to say this is bronchopulmonary sequestration versus CPAM, even if with the feeder artery itself, sometimes there can be mixed hybrid lesions as well. So at times it is very difficult, yes, but the prognostically they do follow different trajectories. And as you said that the risk of eye drops is more in CPAM compared to CLO. And even postnatally also, CPAMs, most of the times they regress, they become smaller, may not require surgery, but a CLO more often than not will require a surgery after birth.
Great. Khurana sir, your take on it.
The problem we've had is that over the years, we did understand that all of these lesions can overlap because they have similar embryologic origins. And we haven't understood why one would be worse or why one would be better. And therefore, it becomes very difficult to give that label, like Alok said. So we shouldn't stick our necks out beyond a point, and certainly not try to overdiagnose or underdiagnose before 26 weeks of gestation. 26 weeks of gestation is what really marks things off, that, okay, it went off, so now we're happy. And beyond 26 weeks, if it persists, we're not so happy. So really speaking, I don't think, because the pathologists themselves are not made up their mind, we really would just presume that this is quite different, that the pathological classification or the pathological approach is completely different from the clinical approach to these lesions. And that includes the postnatal period as well. The surgeons will always look at it from the point of view of resecting every lesion they see on a CT scan. And whereas all of us would always say, look, hold on, it really may have no effect for the next 99 years. And the pathologists will come up and say, oh, there may be a risk of malignancy. That fear of one report of malignancy in one CPAM 25 years ago has made us talk about removing every single CPAM in the first year of life. So we really must emphasize that as of today, we have a much more mature understanding, and we have to sideline the pathologist on this particular matter. We used to always think that the pathologist's word is final. We understand today that it is the imaging word that is absolutely final, because that is the way a disease will behave. Yeah, thanks.
Perfectly said. Perfectly said. Dr. Harshita Shetty, can you take the next question? Can early fetal growth restrictions, especially in the third trimester, differentiate PWS from other causes for hypotonia? Dr. Harshita?
I think this is a case for Archana for the Prader-Willi.
Okay, yeah, it's a Prader-Willi syndrome, yeah.
For early
Sorry.
fetal growth restriction, there will be the umbilical artery Doppler changes and the uterine artery Doppler changes will be also there. Whether it be increased resistance percentile will be more than 19th centile, or the absent end diastolic flow or reversal of the flow, like the staging will be there. So we can differentiate with the Doppler study, sir.
No, basically the question is asked is, let's say we have a suspicion of Prader-Willi syndrome. I don't know how we will have that suspicion, but suppose we have it. So can we use the FGR to distinguish from other causes of hypotonia? So
I think the first thing is that Prader-Willi cannot be antenatally suspected. So here in this case, because it was for the past 1 month, the baby was not moving, and the APGARs were always given as 2/10 and 4/10 with a good Leica and a good Doppler, we suspected that there would be some genetic disorder, not Prader-Willi itself. But yes, Prader-Willi will be associated with FGR also. So we can't kind of make a diagnosis of Prader-Willi only on looking at hypotonia. But yes, we would suspect there is something wrong with the baby, and so the test was done. So it was more because the baby was just floating with a good Doppler and baby was just going on with no fetal movements that we suspected the genetic disorder.
Right.
Sir, Purana sir.
Purana sir?
No, this is absolutely true. You know, the fact is that, again, it's the same situation. We see names, we see associations, and at random we happen to pick up a few things. We just must follow systematic things, and we must follow algorithms. As long as you follow an algorithm, we're very happy.
Yes.
True. Dr. Shraddha, can you take a question? What is the risk of extension of glue into the venous side of circulation while doing a Lipiodol histocril injection?
Yes, sir. If this glue extends into the fetal venous system, it can be lethal because it will enter into the fetal venous system and it will lead to the embolism or thrombosis, and that will be fatal because of the tissue necrosis. So while doing this procedure, we should be careful about the direction of the needle. It should be away from the cord insertion. It should be away from the fetus towards the more like towards the placental side, sir. So that's what I mean.
Right. But still there is a theoretical risk that there would be some risk to.
Yes.
Is it advisable to do invasive testing in isolated echogenic bowel, and how to counsel in such cases? Dr. Rucha, can you take this question?
Dr. Rucha? I think Rucha, can you hear? Isolated echogenic bowel, do we do a testing?
Rucha is not there.
Yeah, madam, you can take the.
No, I think Rucha is not able to hear us. Yeah.
Okay.
So basically for an echogenic bowel alone, the likelihood ratio is only 1.6. So it's a soft marker, which is not so significant for aneuploidy if we've done a good screening test or we've done an NIPT. It is more association with infection, IUGR. So if there is an IUGR or a bleed which has happened. Here, if we have association with echogenic bowel, then we would think of testing it. Like here, there was an associated gallbladder absent. So then it becomes important to test this fetuses. But only echogenic bowel, If your screening has been done very well, the likelihood ratio is not very high for aneuploidies.
True.
Mm.
In the same vein, in echogenic bowel, how to differentiate cystic fibrosis from early meconium peritonitis on ultrasound alone? I think Rucha has answered that. Rucha, would you want to
Yes,
take it
sir.
on the forum?
Yes, sir. So when it comes to differentiating, cystic fibrosis will show more uniform bowel changes like echogenic bowel. Echogenicity will be more uniform and mainly associated with non-visualized gallbladder, while in meconium peritonitis, it is more of focal punctate echogenicities and usually associated with cystic masses like a meconium pseudocyst. It can also resolve later on in on subsequent ultrasound follow-ups. But cystic fibrosis changes it will not resolve.
But even in
And the
cases with
meconium
meconium,
peritonitis itself can be cystic fibrosis.
cystic fibrosis.
Right.
Can be cystic fibrosis. So one, we need to look at the history,
Hmm.
parents, and second, look for gallbladder because that is the only clue.
Flinching. And here there was non-consanguineous, but then it was an autosomal recessive disorder in your diagnosis. So we need to test the parents because they would be carriers.
So the parents were tested, ma'am, and both were carriers for CFTR gene mutation. So for subsequent pregnancy, we will have to test every pregnancy as there is a 25% recurrence risk in every pregnancy.
Fortunately, the first child is normal. Actually, the second is also normal. Maybe the first one was also not tested.
The other thing that we could mention in the counseling is that it's not necessary that this is a lethal disorder and that they can have a reasonable quality of life and manage their daily life. And so there is always the option of carrying on without testing. But in the Indian context, of course, most patients would opt to terminate. But it's nice to give some of them the option. And a lot of IVF people I notice now are very happily carrying on with their pregnancies.
This patient also, sir, we gave an option. They wanted to continue and they are very happy with it. We called them up just before this presentation and they said, baby is fine, everything is good, nothing is wrong with it.
Excellent. Yeah.
Dr. Bansal, can you take a question? In monochorionic twins, how do we decide the optimal timing of delivery or intervention when amniotic fluid differences are borderline?
So the guidelines, we have the guidelines in place and Khurana sir is going to get us through those twin guidelines. For monochorionic twins, the delivery has to be, if it is MCDA at 36 weeks, DCDA at 37 weeks and MCMA at 34 weeks. So that is how we follow. So borderline liker is, and nothing is borderline. It has to be significant liker to assess, but otherwise all monochorionics which are diamniotic at 36 weeks of gestation. Intervention will depend on what is the reason. So you will never intervene if there is no indication. So intervention should always be done when it is absolutely required because all these interventions have got risk. So don't do anything which is not required, especially with lasers. So I think Khurana sir can take it from here.
I would fully
About
agree
our
with that.
fingers,
Really, yes.
we do something which is not required, sir.
You know, sometimes our fingers itch to do a procedure because we possess the instrumentation or because we just want to have the pleasure of an experience. I don't think that applies to medical practice.
Yes, sir.
Yeah.
Dr. Manohara has asked, do labs offer CFTR gene panel or only whole exome sequencing should be done in cases of suspected cystic fibrosis?
So I think we don't have a geneticist on board here today. CFTR gene can be done separately itself. So if we are very sure it is cystic fibrosis, we would do just a CFTR gene. But otherwise, if we don't know and we are not sure of the diagnosis, then a whole exome is going to help us.
Perfect.
Yeah, and also with the whole exome, we'll have to go on and make sure with the Sangha that it is indeed the defect that we have noticed. And so therefore, if we know that it's cystic fibrosis, then the job becomes easier. We go directly to the test. It's only when we don't know the situation, then we will show exome and then we go on to Sanger sequencing.
Yes.
Perfect. So it's almost 10:15 and we are through with all the questions. Anybody among Dr. Khurana sir or Dr. Bansal or Mohit Shah sir, if he's there, would want to have a final word before we wind this down, this session. And there are almost 176 participants at this particular moment. So thank you, Khurana sir, for making this possible. Dr. Alok for continuous guidance and for allowing us 9 participants for this young guns. It was really nice of you. Thank you very much.
It,
Bansal madam, would you want to say something?
it was, sorry, yeah, go ahead.
No,
Yeah, please,
sir.
please.
Just thanks to the whole team, Ashok Khurana sir, Mohit, Alok also for letting all 8 of us to present. So there was a first thinking that we would only get few of them to present, but all of the cases was so nice that we requested Khurana sir to let us present all the cases, and I think it was a nice.
9 of us. 9 of them.
Yes, 9 of.
It's really marvelous learning stuff. You see, I mean, how can you
Yes.
not allow this in? It's world class. I knew that you would pull it off with special training of each one of them, and I think the presentations were fabulous. Like Mohit said, they really show pieces which the YouTube channel will show us for sure. That when this goes onto the YouTube channel, this is going to get so many hits that it's actually going to bring us income into Society of Fetal Medicine. So not only learning, but income and beautiful access to cases like this for anyone anywhere in the world to get onto our YouTube channel. I would also like to take this chance to tell everyone that we must subscribe to our SFM YouTube channel. Some of us do visit it, but we forget to subscribe. Then you don't receive notifications of what is new. So please go ahead and make sure that you subscribe to the SFM YouTube channel.
Mohit sir.
Yeah, it indeed was an excellent show today, and I'm so happy for this. And I really want to thank Shlok, Alok, and you for taking this through. You know, when they said 9, I said yes, we have to have 9 because it's the first ever from Mumbai, and it will set a precedent. I want this enthusiasm to continue. I want more and more. Uh, of young guns participating, and you, Himangini, have done a wonderful job of mentoring them to present their cases. And I want this trend to continue. Both Himangini, if you're there, you and Vandana, I think you're doing a great job. Keep mentoring, and we should have more and more coming from Mumbai very often. Let's increase the frequency now.
Will do, sir.
Yeah.
Alok has to give us time next 2 months. We will have one more young guns back.
I am bombarded by various chapters as well, and they are also wanting to showcase their young talents. So I think you will have to wait for some time.
That is true.
We appreciate that.
Yes, but we have tremendous opportunities. We have so many outreach programs coming up where I really think that we should now make it live, and all our participants should make it to our outreach programs. It's great to be part of an outreach program and to learn the experience. Also, when you're there, you learn how to organize a program. So that'll be a great experience for so many of them as well. And then we have other opportunities whenever we have our state meetings. We always include abstracts in our main program, depending on the quality of the abstract and those presentations. So I want each one of them to grow. So this is not our only forum. And of course, we will give them multiple chances in the year ahead. But like Alok said, there is a huge amount of rationing on what each of these 18 regional chapters can do. So we'll have to consider everyone one by one.
Yeah, so there's also one more channel which people forget, and it has international audience. We have SFM Twitter channel or X channel. So if you have an interesting case which is well worked up, you can send it to us. We will showcase it on our Twitter channel. It has a lot of people visiting from all across the globe. It's fantastic. We post a quiz every Sunday and we post the answer every Thursday. So if you are keen, you have very nice cases, you can always share with us and we will post. We'll do most of the legwork. You simply have to send our cases.
Yes, and some of our cases have had as many as 65,000 views occasionally all over the world. Now, 65,000
Wow.
is a
Wow.
much viewed case. So you can be really, really proud of things like that. Yes.
All right.
Okay, then.
Great,
Thank you.
great.
Thank you again.
Thank you. Thank you.
And wonderfully done, all participants. A wonderful job today. Sleep well tonight. Thank you.
Thank
Thank
you very
you.
much.
Thank you
sir.
very
Good
much.
night.
Good night.
Bye.
Bye.
Thank you.
Good night.
Thank you. Thank you.